Welcome back. We're selling this pair of glasses. Does anybody recognize them as lost? No? Okay, we're going to just set them right up here. Please help yourself if they look familiar. Our next panel is really going to be a fun one because all of you who have worked on program implementation, when you're in the field, if you don't have drugs of high quality or you don't have the drugs where they need to be in order to be properly used, know the incredible frustration. And you can spend millions of dollars in programs that are really very, very poor in terms of effectiveness if you don't have high quality drugs and don't have a good logistics system so that they really are moving far out into the periphery. I think that you're going to enjoy this afternoon's panel because we're going to now really focus on some of these issues. And our first speaker is Grace Adeya. She's a senior program associate from Management Sciences for Health, Strengthening Pharmaceutical Systems, or most people know it, I think, just as SPS. Her talk this afternoon is going to be Supply and Logistics Systems. What do we know from strengthening pharmaceutical systems? The MSH experience and survey data. Welcome, Grace.
All right, thank you. Despite the very sort of long introduction and what's written in the title of the presentation, I actually had to narrow down the focus of my presentation because, as you all know, when we start talking about a pharmaceutical system, that can be we can spend all day just talking about what the issues are and what some of the challenges are. So I'm going to basically, I've put up this framework for improving access, which is really the framework within which we work. We're trying to improve access to essential medicines. We want to make sure they're safe, efficacious, and of good quality, which is really the center, the white part. But there's 4 different sort of parameters that we look at: geographic accessibility, acceptability, availability, affordability. I'm pretty much going to look at just one aspect of affordability in this presentation, which is really the prices of the drug products and services, and present some results from some survey data we've been doing, trying to get a better understanding of the prices of uterotonics. And I'm also going to touch a little on issues around availability, particularly issues around storage and inventory management, which is really the low-hanging fruit in terms of the health system, what we can do with our limited resources and limited time at this point. So that's basically the focus of my presentation. I just threw this slide in there just to give you a better understanding about, when we're talking about availability, which is the first part of this presentation, what are some of the determinants? What are some of the issues that affect availability? And this slide, this cycle is one that we usually use to represent that issue. So whenever you have a stockout, which is usually the basic indicator that you have an availability problem, the reason behind that stockout can be decisions, challenges, issues that have occurred anywhere within this cycle. So, like I said, that's a very huge universe. Today we'll focus specifically on that distribution issues, which I think is one that is easily ameliorated. To start off, I've thrown this up here. I want you to just take a look at it and think about it. I hope it's clear and you can actually read what's listed. We got this picture and we've actually used it in some job aids we developed for storage that are available via POPPHI. But, I looked at it again a few weeks ago and realized, this is actually an example of poor inventory management. So I'm just going to throw this up there and have you all think about why it is that I feel like this is an example of poor inventory management, and we'll come back to it at the very end. And that is actually misoprostol on the shelf. That's all I'll tell you. So we've, just to give you a bit of context, we've just completed a few surveys in a few countries, just looking specifically at availability of uterotonics and trying to get a better understanding of who is managing these products, what do they know, what are they doing with respect to storage and inventory management of these products. Some of these countries we've worked in the past, some of these countries other partners are working in, and some of them, we've not had time to really be very effective, but it's, a good picture of, at this time in 2009, what are we finding? And these are fairly preliminary results. We're in the process of finalizing all these reports. One of the things that is really striking is just to see, we look just at who is managing the medicines in the pharmacy. And this is not necessarily delivery room people. This is right in the pharmacy, who is managing these medicines. And these three countries actually show a really good example of the variability we see in different countries. Benin is particularly interesting because even though they have a pharmacist in a health facility, that pharmacy is technically owned by the community. So the people who are actually managing this are people who have no health training. That 99% of the people we called commis, we found 52% had the equivalent of a 6th grade education, 41% had the equivalent of a 10th grade education, and 6% had the equivalent of a 12th grade education. These are basically people who are basically at the level of community health workers. So we need to treat them like community health workers and give them the kind of training we'd give a community health worker. When we go into places like DRC, they're mainly nurses. So, they already have a great technical background, so you can talk to them from a different perspective. Ghana, I've not included here, but Ghana were mainly pharmacists and pharmacy technicians. So, that's a very easy, straightforward thing to get them to grasp the concept. This is just demonstrating the challenge that in terms of trying to develop generic tools for training and providing information in terms of drug management, pharmaceutical management, it becomes very difficult because we have to make sure that everything we're doing is specific to what country system exists. One of the other things I would like to highlight, I think the other points really highlight, given the variability, what is the kind of knowledge they have with respect to oxytocin. When we look specifically at storage and inventory management, one of the key issues is almost all these ureterotonics are really sensitive to temperature and humidity and a few other things. Do they actually know what the storage requirements are? Thankfully, in most of all the countries we've been to, they seem to have that basic understanding. We've got almost 60%, except Mali, which is very low. And if people don't know the storage requirements, they're not going to handle them appropriately. So at least once we get that fast threshold, then we can talk about what it is they need to do. When we look at the question of cold chain, because oxytocin really has to be maintained within a cold chain. Benin, I sort of have put not available because I didn't have the exact number there in terms of whether or not they have their own cold chain. But one of the things they told us was fairly interesting was most of the facilities had a refrigerator or cold box. But what they were doing is the pharmacy would keep the oxytocin in the storeroom, in the warehouse, until it's been issued. Then they put it in the refrigerator, which is completely contrary to what we want. So that is really sort of an interesting finding. FIFO is basically fast expiry, fast out. That's what we want them to do. We want the products ordered in terms of expiry. Benin, even though they don't really have cold chain, they didn't have a lot of training. Most of them have had training in essential medicines, basic management, and again, because they're like community health workers, if they're told to do something, they follow it by the rules. So they're told use fast expiry, and that's one of the great things. They'll follow that. So almost all of them knew what fast expiry, fast out meant. DRC and Mali, we have a big problem. So they don't know what it means, so they're not really following it. Job aids to help them in their inventory management, only Mali had. We had some distributed in our work with POPPHI, so they've got some out there. We need to make sure that they're out in the other countries. Oxytocin is widely available. I think this is not really bad in terms of availability of a product, but we also have to remember oxytocin is also used for induction of labor. So this is not really determining what quantities are available. Is this just oxytocin that's available for induction, or is it enough to use for PPH as well? That's a different question that I'm not mapped out here. So given some of these issues, what are some of the actions we need to take? One of the things is training. We've already developed some training materials for the nurses, the delivery room personnel, and that's actually been integrated into the POPPHI training materials, which have already been used in a few countries. We're also now starting to think about developing targeted training materials for the pharmacy managers. These are fairly simplified using some of the tools we've used for drug retail outlet dispensers, so that we're giving them materials which are targeted to their educational level, their understanding, and the skills we want them, the things we want them to do. Job aids. One of the things I've put there, Drug and Therapeutics Committee, is a good title for what we need in each hospital or district or province, is a sort of forum where we can bring our midwives, obs-gyne, pharmacists together to talk about what it is they need, to talk about what products are they selecting, how are they estimating their requirements, who's doing the ordering, who's doing the pricing, so that there's that exchange. We had a really great experience in Ghana where we brought them together and trained them together, and it was a first opportunity for the midwives and the obstetricians to talk. And the pharmacists were just completely excluded, so it was a really great environment. So next, I'm going to move forward to now the issues of affordability and just talk about prices. And we've been looking at prices from the perspective of what's available, what's the sort of prices of the global environment, and then what's the prices within the countries. For the global, it's very difficult to get, uniform prices, but what we went and did, we took a look at what we call the International Drug Price Indicator Guide that's developed by MSH, and that's available online. But just looked at, over the 5 years, we've got Oxytocin and Agometrin here. These are products that are generic, so my expectation was that the prices should be fairly stable, and that is really what we're seeing in this graph. I think there's not much variability over the past 5 years. Interestingly, in these circumstances, from the supplier perspective, Agometrin appears to be cheaper. Once we start looking at from the buyer perspective, that seems to flip. Oxytocin is actually cheaper. This is now the buyer prices over the reported median buyer prices. There's a bit more variability because this really depends on which central medical stores are giving us their information, what their procurement processes were that year. Again, this is not really surprising, so this is also very useful. So this gives us some context, so when we're going in countries and looking at the prices and comparing what the prices are, we use this as the frame of reference. So that said, let me I think I've got data here from 3 countries, Ghana, DRC, and Mali. Ghana is great because Ghana has their national health insurance, and the national health insurance has gone ahead and established basic prices for all medicines. And what we found was, the first column there, I've placed the national health insurance prices. Second column, I've just plugged in the indicator drug price median for the supplier prices. The third column is the buyer prices. And then the last 2 columns are sort of just given the percentage difference. In red red shows the lowest price. And it's really great to see that the Ghana NHI price for Oxytocin is actually lower than what our median from that drug price indicator guide is, because I think that's the one we're most interested in. Again, when we've looked at Ghana a bit more, we went ahead and looked what are the regional medical stores, the public regional hospital, the district hospital, the public health center, then the private pharmacy and private maternity hospitals, just to try and see what the prices are. The blanks are where we didn't really get any data, but, I've bolded which prices are higher than the NHI price. And I think one of the surprising things we've seen is actually the private pharmacy is where you probably will get a good deal more often than not, at least in this set of data, which was very interesting. Then when we looked at Oxytocin prices in Benin, Mali, Benin has a recommended price, but the range of prices we found in the health facilities when, the recommended price was 60 CFR. The range we found was 30 to 200. Mali had no recommended price. Once again, we see great variability in the range of prices that are available at the health facilities. And interestingly, because they use the same currency, we can actually see that Mali base price is almost the same as the higher prices in Benin. So one of the take-home messages from us is, once you start having that basic recommended price, people sort of tend to try and veer towards that price, as we can see from Ghana and to some extent from Benin. So basically, what are the actions we can take to improve affordability? I think we need to really work hard at trying to develop, implement, and enforce pricing policies in all the countries which do not have them. This will be challenging because almost all these countries we work in, their essential medicines are part of their cost recovery systems. So in order to change the prices, you have to change some of their cost recovery structures because their pharmacies basically finance the operations of their health facilities. That said, we also need to think through, something like Oxytocin. If we're saying it's going to be used for every pregnancy, can we incorporate it into the price of the delivery package? Most women, when they come to deliver at a hospital, are given a flat rate fee for their entire labor and delivery. Let's make Oxytocin a part of that package so that it's not priced separately. They don't have to go to the pharmacy for it, and it's held within the labor and delivery ward. That would improve the quantification. It would also get rid of some of this pricing variability because they'd be limited to the initial price. And then just rationalized procurement and distribution practices. In some of these countries, even though they're supposed to procure only from the public sector, there's great variability. People are buying products from elsewhere, from the private sector. So this all affects the eventual prices that of the product to the end user. These are all things to think about, and these are all things we're going to be thinking about. So thank you. So I come back to this slide, and again, that's my misoprostol. But if you look at the label, we've got gynodactrin, and we've got paclitaxel, we've got miconazole and clotrimazole. So this has been shelved where miconazole and clotrimazole should be, which begs the question, did they have no miconazole, clotrimazole? Did they expect this product? Did they know where they were going to put it? Was it a donation? Did they buy it? So there's lots of questions, things that just looking at this picture provokes certain questions as to what exactly happened. Thank you.
Thank you very much, Grace. Our second speaker on this panel is Steve Brooke. Steve is going to speak to us this afternoon about Oxytocin and Uniject. Where in the world are we now? Thank you.
Thanks, Peg. Oops. All right, well, I want to give a bit of an update from what I'll call the pharmaceutical product development trenches, which is where I spend a lot of my time working, trying to encourage pharmaceutical producers and vaccine producers to adopt Uniject for a variety of applications. I'm really glad to say that after many years of working on this product with a number of different pharmaceutical producers, many of whom, or a couple of whom, are no longer our partners for the appropriate reasons, we have found a really good partner with the firm Biol in Argentina, and they do now have their Oxytocin and Uniject available on the market in Argentina as a fully approved, commercially available product. Any of you, and this was the first country in the world where Oxytocin and Uniject has been fully approved. What I'd like to do now is actually show play the product information presentation that Biol created when they launched the product. Tap, tap. In Argentina in September.
According to the World Health Organization, more than 500,000 women die every year from pregnancy and childbirth-related complications. The single most important cause of maternal death is serious bleeding or postpartum hemorrhage. Over 50% of maternal deaths occur within 24 hours after delivery. Each death is a tragedy that affects the family and the society as a whole. a motherless child is tenfold less likely to reach 2 years of age. Postpartum hemorrhage is preventable. Active management of the third stage of labor is a set of interventions developed to speed delivery of the placenta by increasing uterine contractions and to prevent postpartum hemorrhage. These interventions are administering a uterotonic drug with oxytocin 10 IU being the drug of choice, assisting with the delivery of the placenta by controlled cord traction, massaging the uterus after the placenta has been delivered. Active management of the third stage of labor prevents postpartum hemorrhage by up to 60%. The World Health Organization recommends that active management of the third stage of labor should be performed by trained healthcare professionals. Biol, in cooperation with PATH, has carried out studies to make oxytocin 10 IU available in Uniject. The Unitec Device is a novel solution developed by PATH, which enables a safe, simple, and effective drug administration. Hypofusina Biol in Uniject is a pre-filled, single-use injection device that facilitates immediate administration during active management of the third stage of labor. Hypofusina Biol in Uniject provides more simplicity. It is the device of choice for healthcare professionals because it ensures rapid and reliable administration. More safety because it reduces risk of disease transmission. Compact size. It facilitates storage and disposal and reduces waste. Assurance of quality. Each device has a time temperature indicator, ensuring integrity of the drug. The easy-to-use, injection-ready format ensures an accurate dose of oxytocin in a non-reusable, sterile device with minimal preparation and minimum waste. Activation of the Uniject device for use. The Uniject device is comprised of a blister containing oxytocin 10 IU, a port, which is the activation site that joins the needle and the pre-filled blister, a needle cap to protect the needle and activate the device by pressure. Use of Uniject device. After checking the time temperature indicator, open the sealed foil pouch. Remove the Uniject. Hold the port and needle cap and push them together with a rapid and firm movement. Listen for click sound, indicating device activation. This procedure allows the needle to come in contact with the solution. Continue pushing firmly to verify that the space between the port and the needle cap is closed. Remove the needle cap. Administer oxytocin 10 IU by inserting the needle into the patient and pressing the blister firmly until it is completely collapsed. Do not recap the needle. Discard the Uniject according to Safe Sharp's disposal guidelines. Hypofusina Biol in Uniject, an innovation in technology for active management of the third stage of labor. Hypofusina Biol in Uniject, the safest, simplest, and most effective solution for the prevention of postpartum hemorrhage.
I'm going to stop it there in the interest of time. And I think it's a real compliment to POPPHI that the materials and the that you've put together have now been pulled into this company's promotion for its product. So as opposed to promoting a brand of oxytocin for induction of labor, this is now being promoted specifically for AMTSL. And that's the type of influence that I think we want to try to have with the pharmaceutical industry. Now back to this.
Just click from beginning. Oh, from current slide.
Yes, I don't have such modern software. So where are we? In terms of regulatory approvals, the Oxytocin and Uniject from Biol has been approved in Argentina and also now in Guatemala. Biol has applied for registration in a number of Latin American countries, as you can see in the light green in Latin America. And we'll be working with Biol specifically in Ghana and Zambia in 2010 as part of a Oxytocin Initiative project. In India, we're also working with an oxytocin supplier there, and while they technically have Indian FDA approval to sell their oxytocin and Uniject, they actually won't have it available till at the earliest middle of 2010. The two firms we've been working with are Biol of Argentina and then Gland Pharma in India. And as I mentioned, Biol now is in the process. They have launched this product in Argentina and are expanding distribution throughout Latin America. We're collaborating with them for pilot studies in Guatemala, and there are plans for pilot introductions in Nicaragua and Honduras, probably in 2010. Gland Pharma is still in the technical development phase of moving their oxytocin from an ampule presentation into the Uniject presentation. And we expect by mid to end of 2010, they will have the entire technical documentation package so that they will have a full dossier for registration of their oxytocin and Uniject. In terms of challenges facing oxytocin and Uniject, the global rollout of this product can't happen any faster than the regulatory approval in each individual country. And in a sense, we're kind of, I think back to where Melody and Venture Strategies folks were when they very appropriately and very proudly announced the first registration of misoprostol for the PPH prevention indication, which was about 4 years ago, maybe. And, well, we're sort of right at that time zero now. We now have the first country where oxytocin and Uniject is registered and approved, with a couple countries coming behind it. And it's going to take a number of years for the registrations to expand out, and that then can allow countries and programs to begin using the product. There's another challenge, which is that this product has to be commercially sustainable for the pharmaceutical producers. And it's great that lots of people think this is a wonderful intervention, and if we can get it out there, it'll change a lot of lives. But it's also got to be a transaction that works for the pharmaceutical companies, and that's always going to be more expensive than oxytocin in an ampule. There's nothing cheaper than putting a product into a single piece of glass. So this is a product that's going to be a premium product. That's all there is to it. And I think we need to work on figuring out and understanding where these additional benefits and sort of built-in quality assurance functions have the appropriate value to justify an extra investment in paying for a slightly more expensive presentation. But certainly there's continued commitment to reducing maternal mortality, and we do now see these multiple sources of supply of oxytocin and Uniject emerging. So our challenge is to start the virtuous cycle of sort of creating some initial paying demand that can help the companies get their production economies of scale in place, which will allow them to then start offering lower prices, which can hopefully then spin into a further increase in demand. And sort of, I think that's what my future is going to hold for the next few years. I look forward to moving down that pathway with all of you. Thanks.
I neglected to mention that Steve is the commercialization advisor at PATH, and he's been working with Uniject for quite a few years now. And immunizations were the first area in which the Uniject was really very, very widely used. So he has a wealth of experience with the technology. Our third speaker this afternoon is going to be Melody Holan. Melody is the president of Venture Strategies Innovations, and her talk this afternoon is going to be The World of Misoprostol, Strategies and Success of Venture Strategies. Welcome.
Good afternoon, everyone. Many of you know me as Senior Vice President of Venture Strategies for Health and Development. About a little over a year ago, we launched a spin-off second organization called Venture Strategies Innovations, another nonprofit. And all of the work that we had been doing in VSHD under misoprostol has now been shifted into VSI. And the folks that you know in many of the countries where we operate that have been doing this work are now part of VSI. We've been a little bit slow to pull out the formal branding, but that's starting in a little bit more earnest now. So you'll see we're all carrying VSI business cards and a new website coming soon. So just a little bit of clarification. So, well, let me go back for a minute. First of all, I want to say that I am delighted to be here. I have enjoyed being part of POPPHI for the entire length of it, and I want to give a huge amount of thanks to the team and to the partners, because what I'm going to present today couldn't be done without the contributions of each of you. The work, and some of you may not even see the ultimate impact of what you have done, both in your research and in your policy work and in your advocacy, but we're seeing it on the ground where countries are taking this into account and are really moving very, very progressively. So I want to just thank so many people who have been involved with this. It's really a team effort. So what have we been doing? The basics, as many of you know, is to connect this chain between manufacturers of misoprostol and the women out in the community. And underlying all of it is a theme of institutionalization of the policy work needed to get there. So today I'm going to show you some of the results of the activities that have been going on. First of all, regarding registration. So registration is the legal authority to import and sell a specific manufacturer's drug by a specific distributor. So what that means is you have to connect a manufacturer, a high-quality manufacturer, with a distributor and apply to the government for approval. We have built a network of 6 quality manufacturers, over 15 distributors in the 14 countries where we're operating. And these are the 13 country registrations that we have been part of facilitating. So this is us being able to connect manufacturers and distributors and achieve regulatory approval of misoprostol specifically for PPH. The last one just came through a few weeks ago. Another part of this work is to negotiate pricing. One thing that we firmly believe in is price competition. So we don't work exclusively with any one manufacturer or distributor, but we connect multiple pairs of these together to keep the cost as low as possible. And we also break down the price at every step along the chain and negotiate reductions. So right now from manufacturers, we're buying from 5 to 15 cents per tablet, an average of 10 cents. And often that can just roughly double when you actually get it out to the end user with the different margins along the way. But we also work at each place in the margin to reduce, for example, duty-free to achieve duty-free status, to put price caps on margins and things like that, and again to introduce competition. So while registration, the key part of registration, of course, is that this is the platform for a sustainable supply, so that when the projects have come and gone, this product will be in the market, both the public and private sectors, so that it can be used by women on a future basis. It is a critical first step for laying this groundwork, but it is not enough. So right now, we have active country programs in 14 countries throughout Africa and Asia. So when we work in these countries, one of the first things that governments are often looking for is local evidence that this product can be distributed at an appropriate level of access, and what our keen interest is on the community level. So we have 9 country operations research programs that we do in partnership with the University of California, Berkeley. Many of you know our medical director, Ndola Prata. One of these is completed, the one in Ethiopia. The others are ongoing and expect to be completed during 2010. We're looking at the community level as far as even TBAs and community drug gatekeepers, and also at the primary care level, distribution of misoprostol through antenatal care. When we're done with this, we will have enrolled 140,000 women in our studies across these different countries. A few to highlight, since the conversation today has been very enjoyable. I want to also recognize the partner organizations that are the agencies on the ground. We do some of the initial training of trainers, provide technical and financial support, and then really work through local agencies to implement the larger scale. ICDDRB is obviously the biggest number on the graph there. Phenomenal organization, really moving in large scale. The OBGYN societies are also playing a significant role, the social marketers, and universities and research institutions. Next step is each of these research studies involves an element of IEC and, of course, of training. And so what we've started to do is to collect some best practices in IEC. We have it available right now on our website, but I'm also constantly looking for new things to add to this so that we can leverage what others have done in the field. These are from Mozambique. This is a training going on, and some of the posters that we've developed in the brochures to make sure that each woman has appropriate education on PPH and on what she can do to prevent it. By the way, these are all prevention studies. Training, another key element of this, and I want to again recognize partners and the type of agencies that we're working with. We have over 50 partners in these various countries. Ministries of health, professional associations, agencies, as well as part of the pharmaceutical drug chain. Through our partners, we have touched, providing technical and financial support, the training of over 16,000 providers. And providers is from pharmacists up to OBGYNs. Some of these have been implemented by partners. Some of these have been implemented by partners, but we have provided a catalytic and a supportive role to each of those. Long-term sales and distributions. Through our programs and partner programs, we have donated 2.8 million tablets of misoprostol. And what these go for is the operations research that us and our partners are conducting, as well as the training, and seed funding to catalyze, initiate private sector sales and distribution. So these are the countries where there is active private sector sales and distribution. But this is a big area, personally, that I feel the pain in, because we have just started to get this product out there, and there is a tremendous amount of work that needs to be done to really move it through the system. We have the legal foundation, we have the right price, we need to now get it in the further reaches, and we have the infrastructure in place, but more needs to be done. I'm also very pleased that some of the government systems are also now procuring it through their public sector procurement, and right now that is Tanzania and one of the states in Nigeria. Policy institutionalization, and Deb, I'm sorry, I I think we mixed up our numbers a little bit because I think what you picked up on was the 14 countries where we are operating and trying to achieve misoprostol on the essential drugs list. There are, you could call it 4 or 3.5 of these that have added it to their essential drugs list at this point. You don't see Ghana, and Gloria, was loved to hear that this morning, and as soon as we get the printed essential drugs list, I'm going to be celebrating to put that on the list. And then also adding it to national clinical guidelines, these countries, with our support, have moved forward in adding that. So, what's next? Like I said just a moment ago, increasing the scale of distribution and IEC is a critical thing, really generating the demand that is critical for making women aware of what they can do. Training at all levels of the healthcare system. So again, I see that as another demand generation activity. Updating policies and guidelines. You see many countries have moved forward, but there's still many more to go. We're regularly receiving requests from other countries. There are at least 20 countries in Africa that don't have access to high-quality misoprostol for PPH. There's Latin America, a big gap in Latin America. There's more countries in Asia, so there's still a tremendous amount of additional countries that need this. And then finally, tracking progress, sales, training, quality, to ensure that we're having the impact that we need to have. Again, I want to thank you to the agencies, the so many agencies and individuals that have made tremendous strides. This is a result of your contributions as much as ours, so thank you.
If you all would like to come up. Yeah. Well, thanks to the three speakers who were very, very tightly organized in their presentations, allowing us time for discussion. So the floor is open. Who would like to give a comment or ask a question? Yes.
Peg, I just have the mic, so I'll go ahead and ask my question and then pass it back there. My question, I think, is for Melody. I was wondering, in many of the settings where we've done community-based distribution for misoprostol have been in settings where we've done a lot of IENC work and, giving pamphlets so that women understand the dangers and risks of and when to take the misoprostol or when the community-based worker should give it. I'm wondering, with the registration that happens, if it becomes available in the private sector, what are the safeguards that we have to have in place for, open procurement of this drug?
Do I need to do anything? Am I on? Okay. Yes. Certainly IEC is a critical element of the entire rollout. And so in these countries, each country, we are working with the distributors to develop appropriate materials, brochures, posters, education campaigns, and specific provider training. Like I said, the providers from the pharmacist through the obstetricians. So, materials, training, education is a huge, important element of it. Thank you for bringing that up.
Hi. There's a question also, sorry, from Melody. Sorry, if I can talk. Thanks. The array of work is really impressive and very interesting. I have a request and two short questions. The request is, would it be possible for you to either put on your website or somehow make available some outline of your study design, since you characterize these as studies, but it isn't actually clear in this sort of presentation what it is you're going to learn. And others of us who would do things like this would like not to duplicate and learn from whatever it is you're doing. So it'd be really helpful to have some idea of what's coming up. And also, it would also be helpful to know the 6 manufacturers and the names of the products in the different countries. If you could also put that on your website or make it available, that would be great.
Yeah,
and
no
the two
problem.
questions are,
Thank you.
first of all, it was interesting, Steve mentioned that it was great that you were registering the drug. and that he was doing something similar, but in some ways we should also acknowledge the differences, which is that the product Steve is working on can't be available until it's registered, whereas misoprostol is all over the place. And so registering it has a different valence sometimes than one might think. And what I was going to ask you is if you can be sure or have you safeguards so that when you have, companies have to put money into the registration for new indication and repackaging perhaps and even changing labels, etc. So what safeguards might you be thinking about to make sure that the price of the new registered PPH product does not exceed the price of the other products on the market, or in somehow doesn't make those prices go up because people see an opportunity to have a higher price? I don't know. I don't know. It could be that you get competition in reverse, maybe. Rather than lower prices, higher prices. I'm not sure, but I know that there are companies who are not interested in going into market because they feel that they have to, in order to make a product for PPH, they're going to have a higher price. So how do you deal with that? And then the second question has to do with an even more difficult problem, I think, in some ways, which came up indirectly earlier, and that is there's a trend for some governments to decide that, yes, we can use misoprostol for PPH, but because we want our women to deliver in institutions, we will take it out of the marketplace and put it in the institutions. And this has the effect of reducing its availability for other very important life-saving indications for women. And one might even postulate that without misoprostol freely available in some of these places, more women will die from botched abortion than will be saved from PPH. So I think we have to be, as a public health community, very conscious of the indirect or unintended consequences of promoting just the PPH indication and tempting governments to hold on to the drug and keep it off the OTC status, which it sort of is in many countries now, sort of under the radar. So if you could make some comments on that, it would also be useful.
Thank you. Sure. So several of the countries where we've worked in have existing misoprostol products on the market. Most of them haven't, actually. So we've been able to bring in the first and then but that's been even more challenging because if you're the only product on the market, you technically have the ability to set whatever price you want. And we had that happen once. And we learned from it, and from then on, every time we agreed to work with a distributor, we put in price caps into our agreement with them. Long-term sustainability of that is going to be a challenge, but the way we're addressing the long-term is to bring in second and third registrations so that they can't radically increase the price without having a competitive situation. In countries where there has already been a misoprostol product on the market, again, we've put in those price caps with our distributor negotiations, and that has kept their price lower. And then you know what has happened is the existing one has dropped their price. Yeah, it's been really cool to see. Yeah, so right now we have not had the situation where it has incited any increase in prices. Just PPH, misoprostol is totally agree. There's so many other life-saving indications that we need to be able to address. Many of the countries where we have operated have requested that we first address the area of PPH because of it's a very critical one, and it's one that they can address more simply. However, we've just started to move into post-abortion care, and now our goal is to achieve 7 post-abortion care registrations, and we've already got 2 in place. So, being able to expand the use of a drug to other indications is extremely important, and I appreciate you bringing it up.
Thank you. There was a question back in this corner. Not anymore. Yes. If we could just have a mic down here in the front.
Thank you so much. My name is Hadi from Pathfinder International. I'm delighted really to see this presentation, and congratulations to POPPHI for such achievement. And it is really advanced to hear this kind of progress in the area of PPH. I'm very impressed with the Unitec in Argentina and India. But my question about India is that will be available by 2010, or is it that is the registration process? That is one question. My question to Madam Grace, I think you mentioned something about availability of the drugs, and that was very informative presentation. But I noticed sometimes when you travel in these countries, there are some health facilities are in stock out of specific drugs, while the next health facility, like 2 kilometers, has abundance of that kind of drugs. So, and no, there is no kind of shifting of this drug or sharing this drug until the drugs sometimes expire. And my question to Madam Melody, I think that is a good initiative and endeavors, especially in the area of Nigeria. But I noticed that you mentioned the question mark at gatekeeper in Nigeria. Would you talk a little bit about that? Thank you.
Would you like to start, Grace? Sure. So the basic question is a question about stockouts at neighboring facilities, neighboring districts, neighboring regions, which is really a familiar problem, and it's not specific to Uterotonics. Thinking back to that cycle I showed, which I told you that usually this is the result of decisions or challenges at any point within that system. In many countries, the decision about what to purchase or what to procure is really done at the health facility level. And because in most of these countries, we're also in a system of cost recovery, they're using their funds to procure this medicine. So even though they understand that if the medicine expires, there'll be a loss of funds, for them to donate it to a neighboring facility becomes problematic if that neighboring facility does not have the funds to purchase from them, or to actually be willing to sort of give, that whole, there needs to be some way of subsidizing or reimbursing them for the loss of that product. That is one issue. Second issue is really just a question of people don't know what is out there in each facility. Every facility holds onto their information. Most countries don't have a really effective pharmaceutical information system. And there's no one person who's keeping track of where we're losing stock, where the stock's lower and in one place, and how can we move it across to others. We've had some experience, at least from the malaria perspective, with trying to get more coordination and moving products from one place where it's about to expire to others. But that requires a really strong central coordination mechanism, which has been possible with malaria under the Global Fund. So those are two of the key factors. And the third is really just people don't know what's on their shelves. Sometimes the stock managers just are not paying attention.
So I'll make a quick comment about the Oxytocin Uniject in India. The company in India that we're working with at this point is a very strong manufacturer. They are not really a marketer. So while they'll be in a position to start manufacturing and selling the product in 2010, we actually need to connect them in some way with an organization that would actually be launching the product in India. And there's also some work going on in terms of research around appropriate use. So we're not yet clear when the product might be available in India.
So as you saw, most of our studies were involving ANC providers and even down to TBAs and primary care centers. So that's what we like to address because we're looking at scale and things that can be taken to scale. When we got to northern Nigeria, we had a problem because the public sector is largely absent. There isn't a functioning private sector, even drug shops, and women are largely sequestered in their homes. So how are you going to reach these women? So we did a very different type of intervention there, where we had drama groups going through and they would make up skits, and they would go through the communities and share with community leaders, followed by what they call community drug gatekeepers. So these are women, and on their hijab, it has a misoprostol logo on it. And I've seen the pictures of these women. They're absolutely gorgeous, and they have this beautiful white hijab. And they come into the community, and the women now are sensitized to the misoprostol and what it does. And they call out the community drug gatekeepers, and they go through them in order to get their misoprostol, the pregnant women. So it's a unique situation for a unique situation. Yeah.
Many thanks to all of you. Because of pressure of time, I think what we'll do is invite you to interact with the panel at the reception at the end of the day. And again, thank you to the whole panel.